Good evening, everyone. My name is Joel Friedlander, and I am Evo Endo's Chief Medical Officer and co-founder. We are honored to have you join us for this evening's webinar. I will be your behind-the-scenes moderator for this evening. Just a few quick housekeeping notes before we get started. This presentation is scheduled to be approximately 30 minutes in length, and we have reserved some time at the end for questions and discussion. Following the discussion, the session will end abruptly when the event is logged off. Speaking of questions, you will be able to submit a question by clicking on the Q&A icon at the bottom of the viewing window and typing it in there. Only you and the panelists can see what you've typed in. We'll then anonymously read them aloud to the group at the end. Everyone's line is automatically muted to keep the background noise and feedback to a minimum. Please stay on mute to prevent interference. We will share a recording of this session with all registrants via email in the coming days. So please make sure to keep checking those inboxes. Now, with all that fun stuff out of the way, it is my pleasure to introduce you to our presenting faculty, Dr. Nick CaJacob, a friend and colleague from Children's of Alabama. He is dedicated to his patients, the field of eosinophilic gastrointestinal disorders, the process of successfully bringing innovative care to the patients of the southern region of the United States. As I have gotten to know Dr. CaJacob, his commitment and understanding of what it takes to bring something new to the practice of medicine has been truly amazing. He navigated and successfully introduced a new technology, navigated his health system, and now offers to his patients and his partners' patients on a sedation-free endoscopic options for their gastrointestinal care. But I also mentioned he's an avid fan of Cincinnati sports and, similar to I, a passionate beekeeper. Maybe if we are lucky tonight, he will share with us some virtual honey. Dr. CaJacob, we thank you for the presentation this evening and for sharing your expert knowledge about the impact of bringing sedation-free endoscopy and the impact it has had on your patients and practice. Our participants, we hope that you enjoy learning from him as much as we have enjoyed working with him. And I'll turn it over to you, Dr. CaJacob.
All right. Thanks, Dr. Friedlander. That was a very warm introduction. I really appreciate it. All right. I'm going to get the Zoom going here. Share my screen. Sent. All right. So welcome again, everyone. This is really my honor and pleasure to be talking with you tonight on the impact of bringing sedation-free transnasal endoscopy to a pediatric GI practice. This is something that is fairly easy for me to talk on because I've experienced it firsthand over the past 2 years, really, and have learned a lot along the way and hope to pass some of those tidbits of information on to you tonight and really help you better understand the global picture of why sedation-free transnasal endoscopy really can have a lot of benefits for you and your practice. So the objectives tonight, first we're going to outline the journey of bringing sedation-free transnasal endoscopy to Children's of Alabama, discuss our experiences as we approach the first year of our program, explore the benefits of sedation-free TNE related to disease management, clinical providers and researchers and how they can benefit, patients and their caregivers, which is pretty intuitive, but I'm going to give you a couple of really good examples. And then looking at the hospitals in your practices and how they can benefit from the addition of sedation-free transnasal endoscopy. So the start of our journey really is rooted in this publication that Dr. Friedlander and his group at when he was at Colorado Children's published in 2016 on their experience from a few years earlier, where they looked at 22 patients with eosinophilic esophagitis. They had 21 agree to undergo transnasal endoscopy, which is really testament to the excitement and the passion that patients and their families feel towards having sedation-free endoscopy as an option for their endoscopic reassessment. And it's a theme that we'll revisit throughout the night. And at the time, I was one excited third-year pediatric GI fellow looking to embark on a career caring for children with DOE. So I was chomping at the bit to get this locally in my neck of the woods. The next mile marker along the journey was the announcement that the FDA had cleared the Evo Endo system for use of unsedated transnasal endoscopy. This was happened in Valentine's Day of 2022. And shortly thereafter, we were contacted by Beth Allen, who's happens to be on tonight, it looks like, and co-founder of APFED, the American Partnership for Eosinophilic Disorders, patient advocacy group, really that has dedicated and been a huge part of advancing the care for patients with EOE and other eosinophilic GI disorders, and who was part of the Evo Endo group early on, reached out to us and asked about our interest in standing up unsedated transnasal endoscopy at Children's of Alabama. Very quickly replied with an enthusiastic yes, but now what? Now what do we do? So this is my very high-level view of the steps to standing up a sedation-free transnasal endoscopy program from scratch. This is a topic that's been covered previously in this webinar series from a variety of perspectives, including from a provider, from a division director, and from the support staff's point of view. So I encourage you to look at those if you want more specifics. But the first part for me was having a compelling story and explaining to the stakeholders why you want to bring transnasal endoscopy to your institution. For us, it was easy. There's a huge patient population of folks with eosinophilic esophagitis. We had a subspecialty program dedicated to that patient population, the Alabama Center for Eosinophilic GI Disorders. And the patients and families were voicing their own desire for this through our clinical interactions and through our yearly patient education sessions where we asked them, what do you want? They would consistently say, we want transnasal endoscopy. We've heard about it and we want it to come here. And the other story that you need to be able to tell is how to create really a win-win-win situation for you, your team, the patients, and the institution you practice in. And hopefully some of the points that we'll go over tonight will give you the ammunition to really go to your stakeholders, go to your administrators, go to the decision makers, and be able to make that why argument. Secondly, you need to get your timing right. We had not set up a transnasal endoscopy program previously. So, prior to Evo Endo, there were off-label use of bronchoscopes that were used at a few centers around the country. This had advantages and disadvantages for us. Ultimately, we're able to fill in some needs that our GI lab had to have patient volumes where they had lost a service and they had some availability. And we capitalized on a lot of our available resources to limit our startup costs, which was another story to tell in the first category of why this is a good idea. The third step was making friends. So initially we teamed up with our GI lab, their leadership team at Children's of Alabama, and the group at Evo Endo to navigate the foundational work of standing up a TNE program from scratch. Luckily, there's a great deal of experience to draw upon, and we were able to move on to the next step, which involves making more friends. And at this stage, we had to involve a host of people throughout the organization to ensure the project was a success. So some of the examples include the value analysis committee that really took a look at the logistics of what we were doing. Were we able to purchase and store the equipment? Was it something that was economically feasible? So they were a really important stop along the way. We talked with our risk management and legal departments to make sure that we were able to do this in a safe manner and effective manner. We talked to our information technology team to set up the connections between our legacy systems, our EMR, and the Evo Endo software. And we talked to our billing team to make sure that this was something that we would get paid for. So once we'd navigated these hurdles, it was time to prepare for launch and doing our first TNEs. And this really required a lot of practice. So we practiced on the Evo Endo head model, which was really cool and really helpful. We practiced on each other. We practiced the patient flow, walking from registration to our clinical area, to what does that look like when they're leaving the building. So we did all those walkthroughs. We even practiced, what if things go wrong? Where's the nearest crash cart? Where's our our code button, and finally we practiced charting and billing a case, and we were ready. And this phase was super helpful when it came time to have our first day of cases. So I can't emphasize enough how much that really set us up for success. And then one of the most important aspects was building intentionally the program for consistency from the beginning. And by this, I mean that we consciously made decisions around how the program would function to maximize the chances of long-term success. Some of these choices included starting with only 2 providers, and the 2 providers being myself and the other main provider in our EGID program, our eosinophilic GI disease program at launch. This allowed for us to gain experience fast. We got a lot of cases early on. We chose to have a half day of transnasal endoscopy every week with alternating coverage between myself and the other provider, so that we would have cases consistently. And as a team, we'd be able to learn and build the program consistently over time instead of having really sporadic cases and not being able to get that consistency down. And then we also decided to be more selective with our patient population at first, focusing on kids 10 years and older with EOE only that had the need for really only an esophagoscopy rather than a need for evaluation beyond the esophagus, so that we could get comfortable with the system and with the process and with the endoscope. And then we really quickly loosened these restrictions as a team after we gained confidence in our processing. And we'll touch base on how some of these decisions that we made early impacted our first year of transnasal endoscopy at Children's of Alabama, as well as discussing insights from other centers' experiences with sedation-free transnasal endoscopy throughout this talk. So the first lens to help us focus on the benefits of sedation-free transnasal endoscopy program is thinking about how it helps achieve successful disease management. I'm biased, but in my opinion, EOE and sedation-free endoscopy are a perfect match. As a provider that really focuses on kids with EOE and other eosinophilic GI disorders, like I said, I was so excited for this. And what this builds on is the 2018 AGREE guidelines that were helpful in many ways, but one in particular was clearly stating the following: that because there are limited long-term treatment data available, patients with esophageal eosinophilia and eosinophilic esophagitis need to have close and structured follow-up with symptomatic, endoscopic, and histologic assessment. And, the desire to find a less invasive way to diagnose and assess disease activity predated this statement. But as we touched on earlier, the first group of patients where transnasal endoscopy was reported on back in 2016 all had eosinophilic esophagitis. So this was not a coincidence. This is really a need, a void that was there waiting to be filled. And that void was filled beautifully by transnasal endoscopy. And we'll talk about that. When we think about EOE, a great example of how sedation-free endoscopy has benefited our patients in the disease management is facilitating the empiric dietary exclusion option in our EOE population. This is a great flowchart that came out of the Seeger group in a recent publication that pragmatically outlines how to navigate empiric dietary exclusion in patients with EOE. So I'm going to start in the upper left of the chart. You eliminate foods anywhere from 1 to doing a complete elimination of all allergens, and then you repeat a scope. And unfortunately, if you don't respond, you can't really proceed. You have to respond first. So if we guess right and we eliminate, say, dairy, then we can say, hey, this patient responded to dairy, empiric elimination of dairy, and we're going to add that back. And we're going to wait 4 to 6 weeks before we repeat an endoscopy and see if that resulted in a return of our esophageal eosinophilia, and then that's labeled a food trigger, or if, hey, that worked great and this is a safe food, and now we're going to move on to a new food. And you'll see if you identify a food trigger, really they want you to have this washout phase where you re-eliminate the trigger food for 4 to 6 weeks before adding the next potential trigger food in 4 to 6 weeks. And once you go through this process in an iterative way, eventually you find all the foods that are potentially involved, and you can start maintenance avoidance. And pre-transnasal endoscopy, this was a rather difficult conversation to have with patients. I would find myself saying, hey, this is something that we can do, and it's difficult, but all the options that I'm giving you are difficult. And let's talk about the nuance of why this is important, in that it involves the potential for needing multiple endoscopies with sedation in a short time frame. And so the introduction of unsedated transnasal endoscopy really allowed patients to choose this, and for us to vouch for this and support patients that want to do the empiric dietary exclusion option in a much different way than we could in the era where we only had sedated endoscopy. This study is a further example of the usefulness of employing sedation-free transnasal endoscopy through the lens of disease management. It's a pilot study that was performed at Colorado Children's, where they looked at 5 patients that underwent transnasal esophagoscopy, so just looking at the esophagus, at 2 and 4 weeks post-food reintroduction, plus a 6-week traditional or transnasal endoscopy, although all 5 participants chose transnasal endoscopy for that third scope, again, highlighting the patient satisfaction and preference for this procedure. And prior to this study, the standard of care, like we talked about, was recommendations for timing of repeat endoscopic assessment range from 4 to 8 weeks following food reintroduction. And that was really based on eosinophil physiology as well as expert opinion. And so 3 key findings from this pilot study are that transnasal esophagoscopy was well tolerated and preferred by patients and families. 2, that mucosal eosinophilia following a single allergen reintroduction occurs as early as 2 weeks, where we didn't know that answer before. Now we knew that at least in some patients, we would see return at 2 weeks. And really the most important finding is that it supports the need for future studies to better understand the natural history of mucosal eosinophilia in eosinophilic esophagitis, and really kind of sets the precedent for how to think about other disease states too, and understanding the natural history in those. So we'll talk about that a little bit later. So changing gears, next we're going to explore some of the benefits of sedation-free transnasal endoscopy through the lens of clinical providers and researchers. That's us, you all here at the joining me for this webinar. And so the sedation-free transnasal endoscopy is an emergent medical technology that clinicians and researchers utilize for their benefit. And we'll delve further into each of these potential benefits, including some concrete examples, starting with how it can be used to answer novel research questions. This is a poster that was just presented at this year's DDW, Digestive Diseases Week conference that wrapped up yesterday. It's really cool. Dr. McGill and colleagues at the University of North Carolina report their experience in utilizing sedation-free transnasal endoscopy with the EvoEndo system to answer a research question that was previously inaccessible due to the sedation needs, costs, and risk associated with traditional endoscopy. They recruited 5 subjects who underwent sedation-free transnasal endoscopies pre and post allergen exposure, and a total of 18 transnasal sedation-free transnasal endoscopies were performed, with 14 reaching the duodenum and the remainder reaching the stomach. The patients tolerated this well. They're using the TNE score that we'll talk about a little in greater depth later. All of their patients had either well tolerated or had minimal complaints, a score of 1 or 2. And the procedure took an average about 30 minutes to complete. So the marriage of endoscopic and histologic assessment in coordination with allergen exposure, which is akin to food challenges that our allergy colleagues utilize in the management of IgE-mediated food allergies all the time, really has the opportunity to illuminate the currently poorly understood interaction of the immune system in the gut. And this is a great prototype of how we can do this. Really exciting. Now we'll move on to the benefits of setting up an unsedated transnasal endoscopy program for your personal brand and marketability. So this is awesome. This is Inside Pediatrics. It's a biannual magazine that our institution, Children's of Alabama, produces, and many other academic centers will produce similar marketing materials. And it's distributed widely in both print and electronic form. And it featured our sedation-free transnasal endoscopy program on the cover. So this is kind of the screenshot from that. And this opens up opportunities for philanthropic funding, for patient referrals, for general awareness of our program. Another great example is tonight's webinar, right? So this webinar is a way for me to build my personal brand, increase my national reputation for not only myself, but our program, our division, and Children's of Alabama. And, another way that this increases our marketability is the recruiting of fellows and other faculty members. So fellows that are currently in training can really bolster their applications by acquiring additional training and skills, with one great example being being proficient in doing sedation-free transnasal endoscopy. And then lastly, I'm going to look at how this can aid in academic promotion through service, research, and education avenues. So everybody at academic institutions will be familiar with promotion and tenure, and even those not in academia, advancement and promotion is generally a desirable goal. So it's important for everybody. And every academic institution will have a website similar to this one, that's from the University of Alabama, Birmingham, that outlines the requirements for promotion, with typically 3 pillars being effectiveness as a teacher, effectiveness in scholarly activity or research, and effectiveness in service activities. So I'm currently in the midst of the promotion process, and really was able to highlight my experiences building the sedation-free transnasal endoscopy program as a key area in my service portfolio. Others may use the research they perform using this technology, or by creating training and educational materials to support their applications for promotion. So this is really a pretty versatile tool when it comes to building a case for promotion and advancement. And this is a great selling point on how you can create a win-win-win situation, like we talked about earlier, when trying to garner support from your division director and chair. And so these are just a few ways that you can get involved, even if you don't currently have sedation-free transnasal endoscopy where you're practicing. You can learn more about sedation-free transnasal endoscopy through webinars like this one, through conferences, reading the literature, and lots of other avenues. You can join the NASPGHAN transnasal endoscopy and or EGID SIGs, or specialty interest groups. I put an asterisk there because there's a little bit of transition happening with the EGID, SIG, and other SIGs within NASPGHAN, and so may soon become a formal committee and have other restrictions associated with it. But for now, it's a SIG, and you're welcome to join. You can connect with other centers and experts like us that are utilizing transnasal endoscopy in their clinical practice, and learn from their experiences. And you can always collaborate with others investigating transnasal endoscopy. So there's some ongoing work in how to train providers, and what does proficiency in transnasal endoscopy look like. There's ones that we've talked about, but other studies looking at novel uses in various disease states and use cases. So celiac disease, H. pylori, esophageal atresia, and tracheoesophageal fistula patients that all have a need for repeated endoscopic and histologic assessment of their gastrointestinal tract. So lots of ways to get involved. Okay, so now we're going to transition again to the benefits for patients and their caregivers. So patient benefits. So some, really just off the top, easy things. So you avoid the need for interventions required for the safe provision of sedation. So if you're going to get sedated, you're going to need IV access, and that's a big no-no for many of our patients in the pediatric world. The parents, breathe a sigh of relief at the end of the clinic visit when you're not getting labs. We shorten our MPO time, so we currently practice 4 hours pre-transnasal endoscopy. There's some variability out there, but definitely less than the sedated endoscopy counterpart. And really, there's reduced constraints on post-procedure activity. So where, post anesthesia, I'm telling people, hey, don't, go to any organized activities, no soccer matches, scout, that kind of thing, until the next day. Our patients are getting up, walking out, and usually going to breakfast with their family, and then checking into school. And therefore, they're decreasing their time away from school. I kind of think of this like the orthodontist model, right? So my kids, when they need to go to the orthodontist, we may have sent them to school, pick them up, go to the orthodontist, and go back to school. So the same kind of thing can happen here, where they're really limiting their amount of time away from school. And this is a reversible decision. So really cool that, if patients are unsuccessful, or if they prefer sedated endoscopy, they can always change back to that in the future. So it's a option, and it's not a permanent decision that they need to make. So this slide, really, it's important to consider the differences between sedation-free transnasal endoscopy compared to traditional sedated endoscopy to inform a benefit-risk discussion with patients and their families within the framework of shared decision-making. And this really is a great study because it's the largest cohort of sedation-free transnasal endoscopy reported in the literature to date. It's a little bit old. It's from 2015 to 2018. And it was using the reusable off-label bronchoscopes at Colorado Children's. But really importantly, what they found was that the endoscopic appearance and quality of the histologic biopsy samples were deemed adequate for evaluation, as defined by the representation of all the mucosal layers in the biopsy samples, and all that while the total costs were cut in half. So really, this is saying to me that we're not risking doing a poorer job of assessing your overall disease activity in choosing between sedation-free versus sedated endoscopy. And that's a really important thing to convey to your parents, that I think these are on equal footing as far as the benefits and the risks. There's some trade-offs, some benefits, and some risks that are different either way, but they're on equal footing. And really importantly, I think, talking about the financial implications of performing sedation-free transnasal endoscopy, it's important to note that these are highly dependent on your local context, where you perform the scopes. Is it in clinic? Is it in the GI lab? Is it in the procedural area? Is it in a hospital setting? Is it in a offsite clinical setting? What's your payer mix? What endoscope system are you using? So I'm not going to get too much into the weeds on that, but it's important to assess this when you're in the early stages of starting a program, like we discussed earlier. We pre-certify all of our endoscopies, including our sedation-free transnasal endoscopies, specifically to protect our patients and their families from getting unexpectedly large bills for our services. So that's one way to kind of generally guard against problems there. And anecdotally, I really haven't had any concerns raised from our pathologist, our billing department, our patients through almost a year of practice. And we are planning on completing a more in-depth review of the program, including the finances as we approach our 1-year anniversary. In the same study, so this is looking at the 190 subjects that were enrolled that did a total of 300 transnasal endoscopies over the course of 3 years, with 294 of those successfully completed for a 98% success rate, which is really impressive, Dr. Friedlander. And all but 7 of those scopes were for the evaluation of EOE, again, highlighting that nice marriage between the two. And I want you to note that 54 the subjects, 54 of the 194 subjects, underwent multiple transnasal endoscopies in those 3 years, and 20 of those had 3 or more endoscopies in the 3 years. And as we mentioned earlier, those patients that are choosing the empiric dietary elimination are subjected to the need for multiple repeat endoscopic and histologic assessments in a short time frame. And so the 43 scopes for food elimination and the 57 for food introduction, again, illustrates the benefits for this specific subset of patients. So really important. This next study looked at the feasibility of performing sedation-free transnasal esophagogastroduodenoscopy. So instead of just saying, hey, we're going to get to the esophagus, and that's going to be okay because we're just reassessing EOE, is it viable to say, I want to assess the stomach and the duodenum all together? And again, this is important because we need this data and this to inform our risk-benefit discussions and to guide our practice and what we're recommending to our patients. So this was a single center. Dr. Smati and his group at Arnold Palmer in Orlando, they were using the Evo Endo system. They had 8 patients that were 11 to 20 years old. All 8, they were able to get to the stomach, and 7 out of the 8, they were able to intubate the duodenum, with 5 out of the 8 achieving duodenal biopsies. And the median time for all that was 18 minutes. So again, going back to that, the UNC study is 30 minutes, 18 minutes. These are reasonable timeframes to complete these endoscopies. And really, I'm curious. These data make me curious about the future potential for performing transnasal EGD assessment the same day as an initial clinic consultation. A patient comes in, hey, I have positive celiac markers. Okay, well, let's get you set up for a transnasal endoscopy, and we'll get duodenal biopsies. That's really the workflow that's currently widely practiced in the ENT world. And if we're able to make that workflow happen, it has the potential to further decrease delays in diagnosis, reduce costs further, eliminate time away from school further. So lots of potential out there, and you can be as creative as you want with this system. All right, and then moving to the caregivers, we're talking about the ability to be present for the procedure. So our patients are allowed to bring their parents or their caregivers with them and see firsthand in real time what's going on, and they're able to comfort and support their child. They decrease their time away from work. They avoid the concerns surrounding repeated exposure to general anesthesia and sedation. And they are able to actively participate in shared decision-making, again, with their treating provider. This was a qualitative study that looked at parents and patients' perspectives regarding sedation-free transnasal endoscopy. And I'm just going to share a few of these quotes. The first quote's from a patient that states, it did help to settle my nerves a little bit, because when you're being sedated, your patients or your parents are there, but it's just relaxing to know there's someone in there that you know really well, because even though the doctors are really nice, you don't know them super well, and you've only known them for 5 or 10 minutes. So just having a parent in there to be able to hear them talking to the doctors is just pretty reassuring. So again, having parents there is awesome. Second quote's from a parent expressing their relief at feeling like they have the option to pursue the empiric dietary elimination option for the first time. It feels like now we have a disease that we can actually manage. It feels like there's a huge light at the end of this awful tunnel. Now we can figure out what she's allergic to and not allergic to at 4 times the rate. So really exciting. And finally, a reminder that it's not all roses when it comes to sedation-free transnasal endoscopy. So this is from a parent that could find a spray that had some nice taste to it, kind of a flavor. This is by far our #1 complaint. Topical lidocaine does not taste very good, and I can vouch personal experience. It's disgusting. Okay, and then lastly, we're going to turn to the benefits through the eyes of your hospital and practice administrators. Really important eyes to look through. Once again, spend time exploring each of these, starting with how this allows for expansion of endoscopic services without adding OR block time. So this is a table that I created to compare what's needed to add additional OR block time versus adding what I've deemed TNE block time. For those of you not familiar with block time, it's simply the time allotted for surgeons or proceduralists to complete cases similar to how a clinic template would work. The goal is to fill this time without going over so that costly resources can be effectively managed. And it's likely that the current total OR block time at your institution is near capacity because of this fact. And additional time would come at the expense of another provider or through adding additional ORs, which is an expensive proposition. So I'm going to work through this comparison pretty quickly here because we're running short on time, but looking at kind of a patient flow through a day. So we start with registration. If you're going to add OR block time by adding OR, you need additional space and staffing for registration because those are additional bodies in addition to those that are already existing. With TNE, you can be flexible. We decided to use our referred testing / lab registration staff that was conveniently located to our GI lab. They were already using for other procedures in the GI lab, and they had the capacity to handle our numbers. The one-day area, again, if you're adding OR block time, you need more physical space and more staff to handle those increased patients. With TNE, we're flexible. We have a separate room that we use in our GI lab to kind of before the transnasal endoscopy to say hi, get a patient history, do the consent process, and that's how we just maximize our patient flow. And then physical space. If you're adding OR block time, often you're going to need to add OR rooms or endoscopy suite with the requisite equipment to do not only endoscopy, but all the other surgical specialties if you're in the OR. With TNE, we're flexible. We currently utilize a room in our GI lab that was set up for procedures including manometry, and we flexed it to be able to also support transnasal endoscopy. You can also, depending on your setup, make this a mobile platform, and we did that so that if in the future we want to go to the emergency room or we want to go to the PICU, we can move the cart and get there. Staffing, OR needs lots of staff, anesthesia, scrubs, circulators, OR board, environmental services, scope reprocessing staff. So in TNE, we really only use 2 GI trained nurses and a child life specialist in addition to the endoscopist. And we fill all those roles. So really being efficient with staffing. PACU, you need additional staffing and space in the OR versus in TNE. Again, you're utilizing the same staff and there's no need for recovery because they haven't been sedated. I'm showing them their pictures from the scope, making sure they have all their questions answered, and showing them the door to go home. And who you're competing against is different. So in the OR, you're competing against surgeons and proceduralists and dentists. For TNE, depending on where you're situated, it's mostly a little bit more controllable. It's your clinic, it's your endoscopy suite, it's your GI lab, your space that you have a little bit more control over. And at the end of the day, whether I do a half day of scopes in the OR or half day of scopes in my transnasal endoscopy program, it still counts as the same full-time equivalent effort. So a half day being 0.1 with 10 half days in a week being a full-time equivalent of effort. So this is, really advantage TNE from an administrative standpoint. Okay, I'm going to go through this really quick, but this is just 2 control charts. The top one is looking at our total sedated endoscopies over time, starting in June of 2022. The blue arrow denotes June of 23 when we started doing our transnasal endoscopies. And you can see that we remained very stable with an average of 256 total sedated endoscopies per month over that time period. We did not change the process as we introduced transnasal endoscopy. And below, you can see our sedation-free transnasal endoscopies starting in June 23 on a monthly basis, going through April of 24. We've done a total of 81 now in the first 11 months of our program. And we're really excited. We've kind of consistently been building our numbers over time, again, in building for consistency. So the most important takeaway from here is we did not, like other people have showed in the past, we did not take away from our regular endoscopy or regular sedated endoscopies. We just added transnasal endoscopies in addition to what we were already doing. And then looking at how this serves as a marketing, recruitment, and referral opportunity. Same idea as the personal promotion. This is a screenshot from our 2023 Children's of Alabama annual report that highlighted our sedation-free transnasal endoscopy program in the growth and technology section. And this is a way for, again, Children's of Alabama to educate its supporters, donors, about what the administration is most proud of. And as we previously mentioned, we can use this to aid in recruitment of faculty and fellowship positions, raise philanthropic funds, increase awareness of our program. And this is sent to all of our referring physicians. So this really can also serve as a touch point for our referral base for them to learn about our program and drive further engagement. So really exciting opportunity. And then lastly, sedation-free transnasal endoscopy can improve efficiency and patient satisfaction. This is a visual abstract from a recent article from Dr. Nguyen and the Colorado group describing a novel score to assess the acceptance and tolerability of sedation-free transnasal endoscopy in pediatric patients. Overall, showed 85% of the patients tolerated the procedure with ease or minimal complaints at a score of 1 to 2. And they identified factors that predict difficulty with tolerating the procedure, including younger age, first-time transnasal endoscopy, shorter height. And really, this generally aligns with our experience at Children's of Alabama. So this is something that's rewarding to see that, hey, this is something that patients are tolerating well. And again, thinking through the lens of an administrator, this is a recent study out of Children's Hospital of Philadelphia, showed a reduction in both procedure time and total facility time when compared to sedated endoscopy. So they went from, they saved 2 hours on average, going from 1 to about 3 hours in TNE versus sedated EGDs in their complete facility time. So when the patients come to when they leave. If you think of this through a administrator's eyes, you're also starting to think about secondary and tertiary benefits. So you're potentially saving, and you're making an increase in functional parking capacity. Parking lots are expensive. You're offloading cases from the OR or endoscopy suite and opening up block time for additional cases or providers that need it. And you are increasing patient satisfaction scores as a result of this decreased facility time. They're in and out quicker and they're happier. So in conclusion, we've discussed that sedation-free and transnasal endoscopy is a safe, well-tolerated, and effective alternative to traditional sedated endoscopy. The beneficiaries include clinical providers and researchers who care for patient populations that require really repeated endoscopic histologic assessments, especially. Patients and their caregivers with increased options that allow for participation in shared decision-making and a sense of control. And hospitals and practices that can add value through the flexible addition of endoscopic services. I'll close with a picture from our first day of sedation-free transnasal endoscopy at Children's of Alabama on June 6, 2023. Pictured here, my partner, Dr. Montoya, my GI lab team, Heather, Shannon, Trina, Amy, and Lauren Clint from the Evo Endo team that were always there to lend a hand as we launched our program. So with that, I thank you for your attention and look forward to your questions.
Dr. CaJacob, thank you so much for that wonderful, wonderful presentation. And as Dr. CaJacob had said, the floor is open for any questions. The first question that I would ask of you that came from from our group would be, as you were starting your sedation-free program and going through those various things, what was your greatest surprise, whether that be positively unexpected or struggle or negatively kind of concepts that you would like to share with our audience today?
Yeah. I think I was surprised at, the amount of time and effort it took to get all the things aligned. And it was worth that. It was worth taking the time and the effort. And it was very much appreciated, all the help that we received. But that was surprising. And getting it right was important because that, like I said, really has set us up to have that consistency and be able to now, in launching into our second year, really think about how can we creatively build on the success of our first year.
Thank you so much. Another question that we have is, as you've started your program, and again, after doing 80 endoscopies in that first year and all the learnings that you've had, what is your approach when talking to a family about sedation-free endoscopy and what impact it would have on their therapy, their care, how you approach whether to pick a sedated endoscopy or sedation-free endoscopy? What is your approach?
Yeah, that's a great question. Yeah, so I think really important, I kind of, again, I'm biased a little bit with the EOE population and thinking through that lens. And we know the importance of shared decision making in that patient population. So I approach the endoscopy question very similarly, that I think, like I said, the sedated and the sedation-free really have different benefits and risks, but have similar footing. And so I approach everybody that's eligible. I say, hey, this is an option. And if you have no preference, I actually would lean towards the sedation-free endoscopy as the default, to try and see if that's something that you can tolerate and do and be successful with, because our experience shows that most people are able to do that. And pragmatically, what I do is I say, hey, we need to make a decision today, whether I'm going to schedule a sedated endoscopy or a sedation-free endoscopy. And that's a reversible decision. If you go home and you've thought about it and you talk to dad and you're like, hey, that is not a good idea, then we can switch. That's fine. No skin off my back. And I give them a link to a video that has, hey, this is what this day would look like. And so they have some point of reference. And it's not clogging up my clinic. It's not, hey, watch this video right now and then give me the answer. It's, hey, let's make a decision based on our conversation and look at this video. And if it changes your mind, just let me know. So it really has worked out pretty well. And there's very rare occasions where people change their mind. It's happened, but most people, after a quick discussion, kind of get the sense of, hey, this is something my kid's going to be able to tolerate, or no way, this is never going to work in a 1,000 years. Thank you for the offer, though. And I tell them, and I say, hey, this is something that I know you said no this time, but I'm going to ask again next time. And because you may change your mind, you may have a different set of circumstances, and it may be 5 years later that you change your mind and you decide that, hey, now is the time that we might be able to do this transnasal endoscopy. But I want to continue that shared decision making and making sure that they're aware that they have a choice, and inform them as best I can with the benefits and the risk of each, and help them in making the best decision for them and their context.
Awesome. And another question from our audience. They really appreciate your talk. They really loved it. They said, thank you very much. One of the questions is regarding the charges and the coding. And he said, thinking of the charges and the reimbursement, do you typically charge for the procedure plus an E&M charge, or only for the procedure itself? And again, that's referring to kind of a clinic visit plus a procedure, or a procedure visit plus the office visit together. What is your typical practice? And if you were to offer, that'd be question one. And then the question two, when you're starting your program, what pitfalls would you take to mind during those first few months of implementation? So things that you're like,
Yeah.
wow, now 11 months in, if you could go back and talk to yourself, what would you say? Don't get trapped here.
Good question. Yeah, I like that. Okay. So first of all, in being part of these groups that that I talked about that you should join, the truth is that everybody's doing a little different right now, and there are some places that are successfully able to bill both E&M codes and procedure CPT codes on the same day and get that reimbursed. We're not currently. I probably could with the service I'm providing, as far as in talking to patients beforehand, asking how they're doing, getting an update, talking about, afterwards, hey, this is what we saw, this is what I think we're going to do. So I think I would be justified in doing so. I just haven't yet. And part of it is that where we're doing it is in the GI lab, and part of the ability to do those separately is having separate areas where you're performing those different services. So, it's worth the discussion, and I've had that discussion. I've started that discussion with my group to see if we could swing that, because that would be great. But we haven't yet. We're just doing our procedure codes. And then the second question about what I would change going back. I honestly wouldn't change a lot. I think the thing that I'll change the question. I'll say what I was most happy that I did was in leading up those 6 months or so while we were working on it. I also was talking to patients in clinic and saying, hey, this is something we're going to have maybe in the next 6 months to a year. Would you be interested in doing this? And I created a list of folks, and it was very easy to fill those first few procedure days with patients because I had done that. And it's pretty important to be able to fill those days, because that's when you're going to have the most support. People are going to be there. Like I said, we had folks from Evo Endo, we had folks from clinic, from the OR, from all these different areas that were excited and were willing and ready to support me in those first 2 or 3 procedure days. But that kind of fades with time, and so you want to fill those days, maximize your opportunity to take advantage of those resources, in thinking ahead and getting patients. And there's also, those were the most excited patients. Those were those were like the ones that were like, oh my gosh, I can't believe you're finally doing this, and we're so excited. So it was that was a good call, and I'm glad that I did that. And I might have even done it earlier had I known the timing a little bit better.
Awesome. So we have one last question because we're a little bit over time.
Sorry.
No problem with you at all. Just for keeping track of time and things like that. So last question is going to be for today is, so 80 patients in, and obviously different types of patients, some that love it more, some not as good, things like that. Is there a common feedback that you're given, whether when a patient follows up with you or after the procedure, as, hey, this is, we just did a sedation-free TNE. This is what most people say about it. Or when you're talking to your patients, what do you say that other patients say?
Yeah, I think most patients, with few exceptions, and the exceptions are pretty obvious, are very excited after the transnasal endoscopy about the prospect of doing it again. That they are able to see the benefit. And sometimes even immediately after. I oftentimes are asking whether it's fair or not. Hey, if we had to do this again, would you do transnasal endoscopy or a sedated endoscopy? And for the most part, they are already, and even the kids are realizing, like, hey, yeah, this was not fun. I'm not, don't sign me up again for this tomorrow. But if I need to do this again in order to assess my disease activity and manage this disease effectively, absolutely, this is the way to go. And so that is both reassuring as a person that's providing this, and but also is true to my experience too. I've had 2 of these done now to myself voluntarily, and I would say the same thing. Like, I don't, if I had to have this done, please put it through my nose, and don't do a full sedated EGD where I'm loopy and having to recover and nauseous and sick. When I was done with my TNEs, my nose was a little sore for a minute, but I was eating and drinking within 5 minutes afterwards, and happily on my day, on with my day. So.
Awesome. Well, thank you so much, Dr. CaJacob. And as we discussed prior, so the webinar will end abruptly in a couple seconds as I hit end, but I want to thank you so much for your expertise and sharing it with our webinar this evening. And thank you so much.
Thanks, everybody. Bye.